Good morning. Welcome to the Department of Psychiatry Grand Round Series. I'm Kaz Nelson, Vice Chair for Education. It's my pleasure to welcome you here today. We have yet another one of our wonderful fellows coming through to present Grand Rounds to us and showcase the work that they've been working on over their several years. Today will be Dr. Sheila Sasieta. And Sheila's educational background, she attended Texas A&M University, where she studied biomedical sciences and achieved her bachelor's degree. After that, she matriculated into the Texas College of Osteopathic Medicine, where she obtained her DO, and then on to the University of Arkansas for medical sciences for her general psychiatry residency. And she's now a first-year fellow in our University of Minnesota Child and Adolescent Psychiatry Fellowship. She's worked extensively with patients in diagnosing and treating PTSD across all age groups and has used Prazosin off-label to treat trauma-related nightmares in children and adolescents in both inpatient and outpatient settings. And I'm most interested to see, later on she'll be presenting some results from a case series she's been working on and going to be presenting that data to us to actually quantify some of the results she's been seeing rather than just approaching this in an anecdotal nature. And so I'm really looking forward to hearing what you have to present to us today, Dr. Sasieta, and thank you all for attending.
Okay. Can everyone at the back hear me? Okay? Okay. All right. So I'm Dr. Sasieta. I'm one of the first-year fellows, and today we'll be discussing Prazosin and PTSD. I have no financial disclosures, but I will be discussing the off-label use of Prazosin in children and adolescents. Our objectives for today is to review the epidemiology of trauma and PTSD, review how PTSD symptoms present in children and adolescents, review the current treatment guidelines and the pharmacology of Prazosin, and review sleep studies in adults and children, and also discuss the off-label use of Prazosin in children and adolescents. Many Americans have had a trauma. About 60% of men and 50% of women experience at least one traumatic event. Of those who do, about 8% of men and 20% of women will go on to develop PTSD. In a community sample of older adolescents, 14.5% of those who experienced a serious trauma later developed PTSD diagnoses. The estimated risk of developing PTSD based on specific traumatic events are 49% for rape, 31.9% for severe beating or physical assault, 23.7% for other form of sexual assault, 16.8% for serious accident or injury, 15.4% for shooting or stabbings, 14.3% for sudden unexpected death of family or friend, and 7.3% for witness to killing or serious injury, and 3.8% if involved in a natural disaster. There are several studies showing different rates of exposure to trauma in children and adolescents. In a nationally representative survey of 12 to 17-year-old adolescents, 8% reported a lifetime prevalence of sexual assault, 17% reported physical assault, and 39% reported witnessing some form of violence. In another study of 536 elementary and middle school children surveyed in an inner city community, 30% of them had witnessed a stabbing, and 26% had witnessed a shooting. So how can trauma-related symptoms present in children? For the verbally developing preschooler, symptoms are expressed non-verbally, such as acting out or internalized behaviors, nightmares and disturbed sleep, developmental regression and clinging behaviors. Re-experiencing the trauma can be expressed as generalized nightmares of monsters, rescuing others, or threats to self or others. And traumatic play is often linked to the themes of the traumatic events. It's often compulsive and repetitive in nature, and often fails to relieve any of the accompanying anxiety that they feel. At school age, cognitive development presents with increasing verbal ability, but difficulty with abstract conceptualization. To a notable degree, symptoms continue to be expressed behaviorally and may include regressive behavior, such as bedwetting, clinging behavior, anxious attachment, or school refusal. They have less emotional regulation and increase in externalizing or internalizing behaviors, such as fighting with peers, withdrawal from friends, poor attention, or declining academic performance. They may not be able to interpret the somatic symptoms related to anxiety or re-experiencing, and this may describe their experiences as more of a concrete physiologic complaints, such as stomach aches and headaches. And they will often experience fears of going to sleep or fear of being alone, sleep disturbance, and other event-specific fears have been reported. Pre-adolescents and adolescents are more able to cognitively process their trauma and integrate the experience into the context of their life experiences. With age, the symptoms become increasingly similar to adult presentation of PTSD symptoms. However, for adolescents, abstract conceptions of identity, future, safety, and connection are vulnerable to alterations. For example, an adolescent's sense of foreshortened future can be diminished expectations of getting married or establishing a career or even experiencing a normal lifespan. Those with chronic PTSD may present with self-injurious behaviors, suicidal ideation, conduct problems, dissociation, derealization, depersonalization, and/or substance abuse. And these symptoms or behaviors can often mask the post-traumatic etiology of their disorder. Now on to assessment and treatment. There are several validated clinical tools that can be used in your practice, inpatient or outpatient. The Traumatic Events Screening Inventory, the child version, is used for ages 4 and older. It's an interview. You interview the child to assess for traumatic events, and there is also a parent form of this tool. The Angie-Andy Child Rating Scale is used for ages 6 to 11. It's a cartoon-based pictorial methodology, and it has a nonverbal thermometer response, and it's used for assessing complicated PTSD. And the majority of these tools are based on the DSM-4 criteria for PTSD. The Child PTSD Symptom Scale is used for ages 8 to 18 years of age, and it's a self-report that actually assesses for a PTSD diagnosis. The Child Post-Traumatic Stress Reaction Index is used for ages 6 to 17, and it's a semi-structured interview. There are both a child and a parent version of this, and it also assesses for the diagnosis of PTSD. The Child Report Post-Traumatic Symptoms CROPS is used for ages 8 to 13, is a self-report. There's also a parent version as well, and this just assesses for just broad spectrum post-traumatic symptoms. And the Childhood PTSD Interview is used for children and adolescents. It is semi-structured, and it is used to assess for the diagnosis of PTSD. There are several other clinical tools that can also be used. And the one thing that is important to remember is that when you're using rating scales, you want to make sure you know the age range that they're designed for, what format that they are either self-report or interview style, and then specifically, what are they designed to evaluate? Is it for the diagnosis, or are you only looking for symptoms of trauma? So on to treatment. Based on the VA DoD clinical practice guidelines for PTSD treatment in adults, there are several different levels of recommendations. These are the recommendations for their therapy services. Level A is considered a strong recommendation, and there is good evidence supporting its regular use. These include exposure-based therapy, cognitive-based therapies, eye movement desensitization and reprocessing, and stress inoculation training. The level C recommendation is there's not a specific recommendation that is for or against, but they have been shown to have some benefit. And this includes patient education, imagery rehearsal therapy, psychodynamic therapy, hypnosis, relaxation therapy, and group therapy. And the level I, which is evidence is insufficient to recommend for or against routine use, meaning the current evidence is either showing that the effectiveness of this treatment is lacking, or there's poor quality or conflicting results. And it is unknown if there's any benefit from web-based CBT, DBT, or acceptance and commitment therapy. In terms of pharmacologic recommendations, level A, there's strong recommendations for SSRIs and SNRIs. Paroxetine and sertraline are the only two that have FDA approval at this time. Level B is fair evidence, meaning there is some benefit that they have found from the use of mirtazapine, Prazosin specifically for sleep and nightmares, TCAs, nifazodone, and MAOIs. They did not find enough evidence to support the use of Prazosin as monotherapy, and so it's listed as a level C in terms of treating global PTSD symptoms. Level D is that the evidence showing treatment is ineffective or harmful. The use of benzodiazepines is considered as harmful and is not recommended by the VA DoD guidelines. No benefit has been shown from the use of tigabean, guanfacine, valproate, topiramate, or risperidone. And level I is evidence is insufficient to recommend for or against. Similar, either studies showing that it's effective or lacking, or there are conflicting results. So there's unknown benefit, and this is for monotherapy with use of antipsychotics, buspirone, bupropion. Yes?
Is this for adult or?
This is for adult. This is for adult. Buspirone, bupropion, trazodone, gabapentin, lamotrigine, propranolol, or clonidine. Now, often several of these medications are used as adjunct treatment, but they do not have recommendations for monotherapy. The AACAP practice parameters are the parameters for children and adolescents, and they have different levels of recommendation. The minimal standards apply to more than 95% of cases. And in terms of treatment, they recommend psychoeducation of the patient and family and trauma-focused psychotherapies. This includes your trauma-focused CBT, your EMDR. And these are considered your first-line form of treatment in children and adolescents. The recommendation listed as option is recommended based on emerging empirical evidence, but there's not strong enough evidence to recommend this to being as first line. The following are listed as options. SSRIs, they've shown in 2 open studies, clonidine was found to decrease basal heart rate, anxiety, impulsivity, and PTSD hyperarousal symptoms. And in 1 open study, propranolol was found to decrease re-experiencing and hyperarousal symptoms. Not endorsed is applied to practices that are known to be ineffective or contraindicated. And these would include restrictive rebirthing or holding therapies that are not endorsed by AACAP. The International Society for Traumatic Stress Studies also has the following guidelines for pharmacologic treatment of PTSD in children and adolescents. They recommend clonidine in relatively low doses has been shown in open label trials to reduce anxiety and arousal, improve concentration, mood, and behavioral impulsivity. Guanfacine has been helpful in reducing PTSD-associated nightmares, and propranolol may reduce the arousal symptoms associated with survivors who had history of childhood sexual abuse. Uncontrolled trials of children with PTSD and high rates of psychiatric comorbidity, bipolar, have indicated remission of PTSD symptoms with risperidone treatment. And there was one case series of a juvenile justice reporting of children with PTSD indicated that quetiapine doses at 50 to 200 milligrams per day provided significant improvements in dissociation, anxiety, depression, and anger symptoms over a 6-week treatment period. The SSRIs have received the most clinical attention and are likely first-line choices for children owing to their broad spectrum activity. There was one open-label trial showing citalopram was helpful to reduce PTSD symptoms. And there are a number of open-label trials that have been conducted successfully with carbamazepine doses ranging from 300 to 1,200 milligrams per day and serum levels between 10 and 11.5. They had significant improvement in all PTSD symptoms except for the continued abuse-related nightmares. Low-dose imipramine to treat symptoms of acute stress disorder and sleep disturbance was shown to be effective in one randomized study, but due to the cardiac and anticholinergic side effects, it should be considered only when safer agents have failed. Ciprofloxacin, an antihistaminic serotonin antagonist, has shown limited utility in reducing traumatic nightmares in open trials. But because of its sedative action and generally safe side effect profile, it may be a useful agent in treating sleep onset problems and nightmares. Little, if any, data supports benzodiazepine effectiveness in treating the core symptoms of PTSD. They may have a minor role as short-term adjunct to facilitate exposure task in therapy. A brief review of the pharmacology. Prazosin produces the competitive blockade of alpha-1 adrenal receptors. It decreases the peripheral vascular resistance and lowers the arterial blood pressure by causing relaxation of both arterial and venous smooth muscle. It is lipophilic. It crosses the blood-brain barrier, which is the area we're most concerned with. It's metabolized by the liver, and side effects include postural hypotension, headache, dry mouth, weakness, blurred vision, rash, and drowsiness. There are at least 10 clinical studies of prazosin in the treatment of adult PTSD. They include open-label trials, randomized control trials that have been published, and all of these studies support the efficacy of prazosin, either for treating nightmares and improving sleep, or for reducing the severity of global PTSD symptoms. Based on these studies, the treatment of PTSD with prazosin was usually initiated at a dose of 1 milligram, with monitoring for hypotension after the first dose. It was typically started at night, and the dose was then gradually increased to a maintenance level of 2 to 6 milligrams. Studies of military patients with PTSD have used higher doses between 10 to 16 milligrams at night. So, sleep architecture. One meta-analysis examined studies of control populations of all ages, and they found total sleep time, slow wave sleep, and REM latency decreases as age increased throughout the lifespan. The study revealed that stage 2 sleep percentage slightly increased with age, and across the lifespan, sleep latency and stage 1 sleep percentage increased with age, while sleep efficiency decreased with age. They also found that REM sleep time will increase until adolescence and then begins to decrease throughout life. Sleep disturbances are a frequent occurrence in adults with PTSD, with one study finding 70 to 91% of PTSD patients reporting sleep disturbances. Another study showed 18.8% of patients with PTSD reported nightmares, as opposed to their non-patient comparison group, in which only 4.2% reported nightmares. And several studies have found that the treatment of sleep disturbance with Prazosin, cognitive behavioral therapy, or imagery rehearsal therapy has led to a reduction in sleep disturbances, which has also resulted in a decrease in their global PTSD symptoms. Sleep findings in PTSD. The physiologic alterations of sleep associated with PTSD have been more extensively studied in adults than in children. The most consistent findings are that adult PTSD patients have more stage 1 sleep, less slow wave sleep, and increased REM density. More recent studies have begun to show subtle abnormalities of REM phase sleep, with more REM to wake and REM to stage 1 transitions, which is consistent with the findings of the increased stage 1 sleep. One study of 6 female rape victims with PTSD receiving CBT showed that 5 treatment responders had decreased sympathetic activity during REM sleep, whereas the non-responder had increased sympathetic activity during REM sleep. Animal studies published in both cats and rats have shown the effect of the alpha-1 agonists, such as methoxamine, to decrease REM sleep. And they showed the alpha-1 antagonists, such as Prazosin, to increase the REM sleep. There's a placebo-controlled study that evaluated the effects of Prazosin on objective sleep measures and clinical symptoms in civilian trauma patients. This was a 7-week, 2-period, 2-treatment study that satisfied the criteria for a classic crossover design. REMView was a portable device with head and eye movement sensors, which was used to help define sleep versus wake and REM versus non-REM sleep. The Prazosin group had greater total sleep time, REM sleep, and REM period duration compared to the placebo group. And the Prazosin group also had a decrease in REM latency compared to the placebo group. In 2013, there is a study in fear-conditioned rats who had previously been shown to have fragmented REM sleep, similar to what is seen in humans who have PTSD. For the Prazosin-treated rats, showed less REM fragmentation compared to the untreated rats. Now on to sleep in children. Nightmares occur frequently in childhood and adolescence and are not necessarily associated with traumatic experiences. One meta-analysis found that the rates of nightmares are highest in preschool years, with a peak of 42.2% at age 2.5 years of age, followed by a decline with a final prevalence of 7.3% by age 16. Children who are exposed to trauma can have sleep disturbances, which can present with parasomnias such as night terrors, sleepwalking, and enuresis, early, middle, and late insomnia, and nightmares. More than half of the chronic adult nightmare sufferers reported an onset before age 20, and it is likely that many of them experienced traumatic events in childhood. Adult survivors of sexual assault with PTSD often report nightmares several times a week. And there was a sample of 30 girls evaluating them for chronic nightmares. And out of the 30 girls, 29 of the 30 had a sexual abuse history. Actigraphy has been used in several studies to provide more quantitative measure of sleep disruption among traumatized children. Among a group of inpatient psychiatric children with and without an abuse history, one study reported that those who were physically abused had decrease in sleep efficiency or greater fragmentation of sleep and poorer overall sleep quality compared to the non-abused inpatients or compared to the sexually abused group. The study hypothesized that the sexually abused children may have perceived the hospital as being a safer environment, given that many of them experienced their sexual abuse in sleep-related contexts. In a mixed sample of inpatients and outpatients, actigraphy was used to compare 15 volunteers, 19 abused children, and 10 non-abused children with depression. The physically abused children trended toward having greater sleep onset latency, and they had increased levels of nocturnal activity. The same study also examined the impact of diagnostic status on sleep, and they found no significant effect of each of the patients having a PTSD diagnosis on their sleep parameters. And this suggests basically that abuse, rather than the PTSD diagnosis, is a primary contributor to the disturbed sleep. The current literature for the use of Prazosin in children for PTSD and nightmares is limited to case reports, and we're going to review several of them in detail. There's a case study of a 16-year-old African-American male who was evaluated in a juvenile detention center. He had a past psychiatric history of conduct disorder, and he was found to have PTSD. His trauma-related nightmares were of his witnessing his friend's violent shooting and having seen his cellmate attempt to hang himself. Prazosin was started at 1 milligram at bedtime, and after several weeks increased to 1.5 milligrams at bedtime. During the 1.5 months the patient was treated, he reported a nightmare frequency decline from 7 out of 7 nights per week to 0 out of 7 nights per week. The nightmares returned when the patient, for some unknown reason, had a brief discontinuation of the Prazosin, and the nightmares resolved after he restarted the medication. The other case is of a 15-year-old Hispanic male who was adopted at age 4. He had a past history of ADHD, and he had been admitted for dissociative episodes and hyperarousal behavior, such as jaw fist clenching, attack-like posturing, poor redirection, and hypervigilance. These episodes could last up to 30 minutes, and they were typically triggered by traumatic recollections or negative peer interactions. During the hospital stay, he had been on sertraline, which was increased to 150. He was previously on trazodone and aripiprazole, which had been discontinued. And he was started on Risperdal 2 BID for the aggression and Prazosin 2 milligrams at bedtime, which led to a decrease in his report of of nightmares. In this case, there was a 16-year-old female with acute PTSD following an armed robbery at work. A gunshot was fired above her, and she was forced to remove money from the cash register. The patient was treated with Prazosin 1 at bedtime, which was increased to 2 milligrams after 1 week. The patient reported resolution of her daily nightmares, and her initial CAP score was 67, which decreased to 40 after 1 month follow-up. Her scores on the CAPs for re-experiencing went from a score of 20 down to 6, and for hyperarousal went from 29 down to 14. Avoidance remained about the same. The next case study was of a 15-year-old female with 11 prior short-term hospitalizations for disruptive and assaultive behavior. She had been admitted to a long-term facility with a trauma history of parent neglect in childhood, early adolescent sexual and physical abuse, and prior foster care placement. Prior to admission, medications were nifazodone, trazodone, and zolpidem. Behavioral and sleep difficulties persisted, and the prior to admission meds were discontinued. She was titrated to mirtazapine 45 at bedtime, but she reported ongoing nightmares 4 out of 7 nights per week. Over a 10-day period, she was titrated up to Prazosin 4 milligrams at bedtime, and 1 month later, she reported resolution of her nightmares. And later, she was eventually discontinued off of the mirtazapine. A 16-year-old female with a 2-year history of PTSD after having been violently assaulted with a knife, sexually abused by 3 unfamiliar older boys. She had near daily nightmares. She slept during the daytime from noon to 6 p.m. She was treated for 6 months with weekly CBT, Wellbutrin 300, and Trazodone 150. Her core PTSD symptoms did improve, but the nightmares and daytime sleep routine persisted. The Trazodone was discontinued, and she was started on Prazosin 1 milligram at bedtime. And in 3 weeks, nightmares began to subside, but she persisted to sleep during the day. After 16 weeks of treatment, the Prazosin was increased to 1 milligram in the morning and 2 at bedtime. And 2 weeks later, the patient had finally returned to sleeping at night from 10 p.m. to 6 a.m. This other case study is a 15-year-old female with multiple psych diagnoses, 5 prior hospitalizations ranging from age 8 to 14, multiple prior treatments with adequate dose of neuroleptics, antidepressants, mood-stabilizing agents. She had a trauma history of ongoing sexual abuse by a family member since the age of 8. She had been titrated to sertraline 100 and had CBT for 3 months, which did result in a decrease of her core PTSD symptoms. But there was no improvement in the disrupted sleep, and she continued to have nightmares 4 out of 7 nights a week. Prazosin was started at 1 milligram and increased to 3 milligrams after 6 weeks, and her sleep symptoms significantly subsided after 8 weeks of treatment. And these are the last 2. A 10-year-old African-American male with a past psych history of ADHD, PTSD, removed from the home at 8.5 years of age after physical and emotional abuse, exposure to sexual contact, and medical neglect while in the care of his biological mother. The patient presented with aggressive, oppositional, suicidal behavior and also had core PTSD symptoms and nightmares. He was started on Prazosin 1 milligram at 3 p.m., resulting in a decrease of intrusive memories. After 2 days, a bedtime dosing was added to target nightmares, and he was titrated to a 1 milligram TID dosing regimen. He was also on Prozac, low-dose Prozac of 10, and a stimulant prior to discharge. At his 6-month follow-up, his nightmares continued to be controlled with Prazosin 2 milligrams at bedtime. And this is the youngest patient for a case study, was a 7-year-old male, past psychiatric history of ADHD and PTSD resulting from sexual assault. He had daily nightmares and slept with the lights on, and his family had posted mirrors on the walls of his room. His ADHD had been treated with extended-release dexmethylphenidate, and Prazosin 1 milligram at bedtime was used. This resulted in 0 out of 7 nightmares within the first month of treatment. He did have a brief 4 to 5 day period where he had a lapse in his treatment with the Prazosin, and his intrusive and hyperarousal symptoms did return. But then once he was back on the medication, his symptoms improved, and the treatment remained effective for over 11 months of treatment. And this is just a summary of all the cases that I just reviewed. The Prazosin doses ranged from 1 to 4 milligrams at bedtime with occasional BID or TID dosing, and the patient ages range from 7 to 16 years of age. And this is a case series that I have started working on here at the U. It's a fairly restricted case of patients that I saw in the first 6 months of my training. They were all required to have a diagnosis of PTSD. They all had some form of abuse history, and their nightmare frequency ranged from once a week up to nightly. The dose of Prazosin ranged from 1 to 3 milligrams at bedtime, and there was a very broad range of response to the medication, from no benefit up to 50% reduction of subjective symptoms. All of these patients were inpatient, so I wasn't able to follow them out or further titrate them, but it was a recommendation after they were discharged. But since then, I have had success in treating adolescents with daily dosing, so BID or TID dosing, which has resulted in improvement of their hyperarousal symptoms during the day. So in summary, we know that PTSD and trauma-related symptoms in children and adolescents do not present the same as in adults. We have several validated assessment tools to help identify or diagnose trauma symptoms and PTSD. Our current guidelines for the treatment in children is limited by our lack of clinical trials. We know Prazosin is effective in the treatment of trauma-related nightmares in adults, and we know it improves REM sleep in adults and in animal models. So please don't wait for the patient to have a PTSD diagnosis before you consider using Prazosin, because they can still have trauma-related nightmares even if they don't meet full criteria. And it has less side effects than a lot of the atypicals we use. And don't forget to start low and go slow. That's it.
Thank you so much. And it's delightful to see that in the course of your training here that you're actually taking on a scholarly project and quantifying things in order to share with the rest of the literature, because there's obviously opportunities for that, especially in this case. Was there any questions or points for discussion?
Are there any, is there any data about long-term effects of Prazosin on children or adolescents at this point?
I did not see, I didn't really look into whether there is long-term side effects, but it is used for hypertension in children. It does have the FDA approval, so I don't know specifics though.
Dr. Cullen?
Sheila, that was really, really good. Thank you for that clear presentation. So, are you publishing that soon?
I'm going to try.
Okay.
I want to get some more cases because I only looked at the first 6 months and I really limited my my patient data, and so now I want to just look if they use Prazosin at all versus requiring them to have the PTSD diagnosis and having used the Prazosin.
Are you going to expand your chart review to the clinic?
Oh, I could?
I have a case to talk with you about, so
Oh, okay.
if you're looking to expand it.
Dr. Jensen.
If you're talking about case review, you might want to look at the inpatient data. And, I've heard that atomoxetine is being tried in VAs. And of course, I've tried a lot of atomoxetine, I think with mixed results, but it might be interesting to look at PTSD diagnoses there and long-term rehospitalized patients and some of the different trials. We've done clonidine, and we've done, of course, Prazosin, and we've done atomoxetine to try to get at it, but I didn't hear anything about atomoxetine.
Okay.
Dr. Miller?
So, excuse me, so I thought REM was when people had nightmares. Am I wrong? REM sleep?
So what they're theorizing is that the patient's REM sleep has increased fragmentation, so it's more broken up. And so one of the rat studies showed that there was more consolidation of the REM sleep, and that's why they were complaining it was disruptive, or a portion of it. That's what they theorize.
Okay.
It's disruptive.
And then, is there any particular reason at this point to choose Prazosin versus clonidine?
No, I don't think so.
Okay.
I mean, there were a couple open trials for clonidine.
Dr. Miller, who works with many traumatized adolescents.
Or creates them. No. So are you seeing, what sort of consistency are you seeing in the symptom profile with sort of the PTSD symptoms? Because I really get your point of we get a lot of kids who don't necessarily meet 5 out of the 9 criteria. Are you seeing any consistency in the symptoms that are showing up for the subacute sort of cases?
So the people that I think of in terms of that I use the BID and the TID dosing, those were the patients who had a lot of the hyperarousal, hypervigilant, tense all the time, easily startled that we saw. I'm thinking one person in particular, she couldn't stay in group because she physically always looked tense. And so we were able to get her to 3 times a day dosing. And the staff was just like, oh, this is a miracle drug. Why don't we just start giving it to everyone with the trauma history? What I would recommend is it would be helpful if we, like I noticed this going back through my charts, I did not do a great job of quantifying. So when they did say they had nightmares, on some people it just said they have nightmares. It would be helpful if it was more like 7 every night I have a nightmare, or 3 times a week. And then also including more of the PTSD rating scales so that we have some way to actually objectively measure what kind of response we're getting from them. So those are things that I know I will start doing from now on. And then I'd be looking for in other cases.
Are you seeing any consistency in dissociation with these folks who are being more responsive?
I have not, but there was two of the case studies did say they had improvement in dissociative type episodes.
That's the case that I'd like to report on.
Any other questions? Dr. Olson.
Dr. Olson, yes. Good call. Is Prazosin available in less than a milligram tablet? Because I had a patient, an adult, that I started on 1 at bedtime, and then it was partially helpful, and she had a lot of arousal during the day, but she couldn't tolerate a full milligram. And the EPIC showed that there were 500 microgram doses, tablets available, but pharmacy couldn't get them, or so I had to have her cut capsules in half, something.
So from my understanding, they either cut the tab in half, or the pharmacy, because I had someone, we started her on 500 also, and they said they open the capsule and they adjust the dose, and that's how they would send it to the patient. Like it doesn't come in that small of a dose. So that's why most of the people start at either 1 milligram, or they cut the tab in half, if you're able to get it in a tab versus a capsule.
So there are tablets. I don't know.
I thought, no, are there not? We'll have to look.
Does anybody know? Pharmacists
I thought
here?
they
No?
came in a tab. Okay, so capsule only. So the pharmacist will do it for you here in the inpatient, but not in the real world.
Get your paper published, and then maybe the companies will make a smaller
They
tablet for
compiled
kids.
Oh, they compound it. Okay.
Okay.
Specialty pharmacies may compound, just for the
Compound.
people watching, streaming online, live. Any other questions? Great, we'll end there. Thank you so
All right,
much.
Thank you.
You have been